All right, great. So today I'm going to talk about how to do extracorporeal cardiopulmonary resuscitation, or e-CPR, for out-of-hospital refractory ventricular tachycardia fibrillation cardiac arrest. No disclosures that are relevant to this discussion. I can figure out how to move this thing forward. There we go. So there are over about 350,000 annual out-of-hospital cardiac arrests in the States. The survival is about 10%. Pulseless VT, VFib is about a quarter of these cases, with it's believed that a significant portion is due to acute cardiac ischemia. Now, 20% of these patients will achieve ROSC with ACLS, but the remaining 80% will have refractory cardiac arrest and essentially mortality. So this patient population, the refractory cardiac arrest, we need to devise innovative strategies to bridge the patient from the field to the cath lab with potential revascularization and recovery. So that's where e-CPR plays a role. So e-CPR essentially is ECMO adjunct to CPR, and as the previous lecturer nicely illustrated what ECMO is and developed in the 1970s to perfuse the organs, and especially in this case is to perfuse the brain, which is typically the rate-limiting step in this patient population, which causes their death. Schematic on the right shows the ECMO. We do these in these cases. It's femoral access. We typically use a 25 French multi-stage venous cannula, a 15 or 17 French arterial cannula. And there's been a handful of studies showing e-CPR showing encouraging outcomes, limited number of patients, but have shown at least encouraging results in this patient population of refractory VT or VFib. So how do you start? You first need to bridge the patient from the field to the cath lab, and that's where automated CPR devices come in play. These are extremely important. They have shown to have good perfusion, good cerebral perfusion, but very important when the ambulance is flying down the street to the hospital. You cannot do adequate CPR if the ambulance is flying, and it's not even safe for EMS personnel, so you have to have an automated CPR device. By the time EMS goes to the scene and gets to the cath lab and you put them on ECMO, it could be 40 minutes plus, so you have to maintain good perfusion, particularly to the brain. This is an example of one of the devices. In our community, this is the Lucas device. Here's a patient that came in to us about a month ago, just to show you, if you haven't seen that, very effective compressions. So next, the patient comes in. You can see the Lucas device is moving in the video on the left. This is a patient about a month ago. It was an e-CPR alert. We get arterial venous access. You can see the picture of the ECMO, what it looks like in the middle. Again, nice lecture previous that explained that very nicely. We do distal perfusion prior to the patient leaving the cath lab to protect the lower extremity. Now, how do you develop an e-CPR program? Well, the first thing is you got to partner with your local emergency services. And we are in Columbus, Ohio. We partnered with the Columbus Fire Department. Columbus Fire Department has stations throughout the city proper, which serves about just under 1 million, not including the suburbs. Columbus is about 2 million. And here's our protocol. This is a multidisciplinary algorithm that was developed with interventional cardiology, cardiothoracic surgery, cardiac anesthesia, our perfusionists, and of course the Columbus Fire Department. Looks pretty simple. It has all the steps from the field to the cath lab to ECMO to the ICU, but I will tell you this took months and months of preparation, took multiple meetings. It was difficult at times to come to consensus about what the criteria was going to be. And we had dry runs. Every single person was assigned a role for efficiency, and so things can run smoothly. So let me just break this down for you guys. So EMS arrives to the field. So what do we define as refractory VT, VFib? That's 3 unsuccessful defibrillations. If they remain in VT, VFib, an e-CPR alert is called to our university. The patient bypasses the ER and goes right to the cath lab. Now, if there's asystole or PEA arrest at any time, these non-shockable rhythms and studies have shown that e-CPR has very poor outcomes, low survival, and low neurological recovery. So we have excluded this patient population from our program. So the cath lab, this is the team that arrives to the cath lab. Usually it's 20 to 30 minutes. And typically these happen in the daytime, so most of the time we're there. Usually when it happens in the middle of the night, the patient's found the next morning cold. So typically we're there waiting for the patient. When the patient arrives to the cath lab, the first thing you do is you get an ABG. We're looking for a lactate equal to or less than 15, a PO2 equal 2 or greater than 50. This is based on our experience, based on other centers' experience, and based on published data that help predict who will survive and who will have decent neurological outcomes. We're also looking for end-tidal tube volumes of equal or greater than 10 to show adequate perfusion. If this is met, cannulas are placed, ECMO started, automated CPR device is stopped. We do a coronary angiogram to look for a reversible cause, thinking that most of these potentially be due to ACS. PCI is needed, then transfer to the ICU. So let me show you a case. It was our very first case when we developed our program, September of 2017. This was a middle-aged man in cardiac arrest, witness arrest, CPR initiated, EMS arrived. He was found to be in VFib, defibrillated him twice, still in VFib, and per the Columbus Fire Department, the third shock, they do a dual sequential, 2 sets of pads, defibrillate, maintained in persistent VFib, intubated, epi, amio, e-CPR alert was called to our institution. Automated CPR device was placed. This is the cath lab team waiting for the patient. Every single person here has a role. They know what to do when the patient shows up so that it's not chaotic, so it runs smooth and it's efficient. So the patient came in, ABG was obtained, lactate was 7, PO2 was 78, end-tidal tube was 40, so it was a go. Cannulas were placed, patient was placed on ECMO, automated CPR device was stopped, and we did a coronary angio, thinking we're going to find a culprit lesion, stent it, and reverse a reversible cause. Well, this gentleman, as you can see, had mild plaque, no culprit lesion seen on the left system. Again, true for the right, too, as well. But when we obtained an echocardiogram, you can see in the peristernal long axis on the left, the short axis on the right had severe LV systolic dysfunction, which we found out was new for this patient. So how did the hospital course go? We found out he was 68, he had a history of hypertension, he underwent temperature-targeted management for 24 hours just to avoid fevers, peak troponin 40, ejection fraction was 25, hospital day number 5, ECMO cannulas were removed, the patient was extubated. Day 6, goal-directed medical therapy was initiated. Day 7, passed a swallowing study, and diet was advanced. Day 8 and 9, physical therapy and cardiac rehab was working with the patient and was ambulating the halls. Day 10, cardiac MRI was consistent with acute myocarditis. Day 11, ICD was implanted for secondary prevention, and day 12, the patient was discharged to home. So on follow-up, he was doing well. No symptoms of heart failure at 30-day follow-up. He had improvement in his LV systolic function, though not normal. He was walking a mile a day with his wife, and he said he was enjoying life. So one thing just to mention is, it not only is it important when you implement your program, but you have to have routine assessment of the program, and you have to have a quality assurance program. So we have routine, scheduled, multidisciplinary meetings, not only internally, but with the Columbus Fire Department to go over outcomes, quality, operational issues, and we make any adjustments as we seem necessary. In addition, we have various venues to go over cases with the fellows, with the staff. This is important, as these cases are not very frequent, so you want to always stay on top of it. So, in conclusion, e-CPR utilizes ECMO as adjunct to CPR. Multidisciplinary team with close collaboration with EMS is critical. EMS programs have shown encouraging outcomes in the out-of-hospital refractory VT VFib, and in 2017, we developed a program to serve our community in Columbus, Ohio. Thank you.